evening. I am so happy to be here. It seems like it's been forever, but it really hasn't been. It's only been a week. But welcome, welcome, welcome. I was sitting here jiving to Mike's music. The ad that you see at the beginning, that is Mike Chua. Mike Chua is a good friend of mine. That is his business in Jackson, Tennessee. And I hope to still make it down there to visit him one day. But welcome, 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 welcome to the Baffled Brain, Demystifying Dementia. I'm trying to simplify my life a little bit. I'm combining my two programs and putting them into one. This is a podcast that will teach you everything you need to know about dementia. I know that dementia seems complex and confusing and challenging to manage, but with the right tools at the right time, dementia can be made simple. Today is September the 23rd, 2021, and it is Thursday. And this is episode 38, and I'm your host, Lizette Cloete from Think Different Dementia, where we believe you are only the right technique away from thriving and not just surviving your dementia journey. So welcome to the program today. If you guys have comments, please throw in the comments that you're watching it live or on replay. Everybody knows what to do. If you have a particular question, please put it out there. I have a few questions that I have pre-prepared or, put together so that I have something and don't just feel like I'm sitting here speaking to myself, which is okay. I've done that before. But I have 6 questions. If I don't get through them all tonight, then I will do the others on Saturday morning when I do the other program. So welcome. Thank you so much for being here. I'm going to put up the first question, and the first question is a sensitive question. And I hope I do it justice. I am trying to always be sensitive to people's needs and their wants, and I know it must be extremely scary at times if you know you have dementia to think about what's coming next. I put myself in that position often. I think about it a lot. I read a lot of books about dementia, and I have worked with a lot of people with dementia, and everybody experiences it differently. But the first question is actually from somebody in the group who asked, how does one die from Alzheimer's or dementia? And so I will try to do it justice. Please understand there are lots of different ways that people go through their life, but I'm going to try to just break it down a little bit easier for the person, hopefully, not to understand, because I'm sure that they do understand this, but to break it down into more bite-sized pieces. So that's the hope and that's the goal. So the first question, how does one die from Alzheimer's or dementia? So remember, Alzheimer's is a type of dementia. Dementia is the umbrella term. Alzheimer's is just one of the types of dementia. So there are lots of different types of dementia. So we're going to use the word dementia tonight interchangeably with Alzheimer's, because typically people who are going through this process, they're two primarily different ways that I have seen that people ultimately pass away, right? So everybody's going to die. We're all going to die. I'm going to die. Anybody who's watching, we are all going to pass away unless the Lord comes back. And so when we're born, we literally start to die. Most of us just aren't dying imminently, right? If you think about your life as a flight, as an airplane flight, when you're in vitro, you're on the runway, you take off, and that's your developmental years. And then we fly, right? We're on a journey, and we have ups and downs. We have some turbulence. We have life, etc. Everybody is going to eventually have some sort of a decline and pass away. Some of us, whether we're 40 years old or whether we're 100 years old, some of us know that we are imminently passing away. A woman could have breast cancer or cervical cancer or anything like that and have a terminal diagnosis. Doesn't matter how old you are, you can have a terminal diagnosis. Imagine that to be your landing phase. Well, if you're flying on an airplane, and if you were to think about that flight as your life, and you have a sudden event like a massive heart attack, a massive stroke, a massive whatever, boom, the airplane crashes and you pass away, right? So think about dementia and dying with dementia in the following way. Some people die with dementia. So they're flying, they have dementia, they know they're ultimately in a terminal process, but the dementia didn't kill them. They had a massive heart attack and up and died. Or they had a massive stroke and passed away from the stroke. It's easier sometimes to tell at the beginning or the earlier phases when something like that happens. Say somebody's got young onset and they have a sudden heart attack and they pass away. So that would be a case of somebody dying with Alzheimer's or dying with dementia. Now, the other part of it are the people who have a little bit more of a longer journey in their dementia decline. And these are the people that as they're going through this process and as everything is changing, how your brain starts to slowly stop doing the things it was designed to do. And so the first thing that we always have to remember is that we all, when we're born, for the most part, follow a certain developmental process, right? And people, and this is particular to Alzheimer's, when people are going through Alzheimer's and using the functional assessment staging tool, they're going to follow a very specific or a generally specific, a typical pattern. And as they continue to decrease or decline through their journey, they will start to have difficulty holding themselves up against gravity, holding an item in their hand like a spoon or a fork to be able to feed themselves. They'll still be able to suck and swallow and be able to take a drink and so on, but they will need help with being fed. And as each of these processes, as our body starts shutting down, and this happens with anybody in a terminal process, whether it be cancer, whether it be somebody who's really end stage COPD, our body starts to shut down, right? And so as this happens, people start to lose their appetite, they stop to eat, they stop drinking, their kidneys stop functioning, their heart rate slows, everything starts to slowly shut down. And when a person, and I had a dear patient of mine, I loved her to death, and I still run into her husband, and we are pretty good friends still. And when I run into him, we speak fondly of her. But she probably died from dementia. She didn't have a process. Her end was pretty fast because she started to have trouble swallowing. And so when a person is dying from dementia, the way I describe it is when everything else has stopped working and then their body just stops. So they're two vastly different ways. Nobody knows when anybody's going to pass away. And I mean, I could walk outside right now and get hit by a truck. I live on a busy street. So don't fret too much if you have dementia about how you're going to end. I would recommend whoever, whether, I'm 51 years old. I just had my birthday this past Sunday. I'm 51 years old. I can't worry about how I'm going to die. I have to worry about how I'm going to live, and I have to enjoy my life. So whether you have a terminal process or not, or whether you have dementia or not, enjoy your life. I know it must be very scary to not know what's coming, but none of us know what's coming. None of us know what's coming. I don't know what tomorrow holds. We're not promised tomorrow. We are promised today. Live in the moment. Enjoy your life to the best of your ability. And if you have any further questions about that, reach back out to me. I would be happy to sit and have a chat with you. So that was our first question for the evening. And anybody who's on live, please ask questions if you have questions. That is the purpose. I come prepared, but it is the purpose of the program is to answer your questions. So I know that that's, maybe not the world's best answer, but I do think that it helps people to think it through, that some people die with Alzheimer's or dementia, and some people die from a terminal process like dementia. So the next question, this one kind of really sparks my interest, because this is kind of what I do, right? I'm an occupational therapist by background and training. I work with people on cognition, and then I work with people at various stages of their dementia journey. And so this is my jive. So this question, the person said, cognitive lessons or ideas for us who have dementia, and which stages would these be helpful for? And then she said, I would like to prepare for my needs and my husband's needs in advance. And so I think this is a great question. So in the earlier parts of a cognitive impairment, and understand none of us know whether or not we, we all have good days and bad days in our thinking. I have good days and bad days in my thinking, depending on how I'm doing, how I've slept, what I've eaten, if I've exercised, which I haven't in a while. All of these things. So we all have good days and bad days, and we have to give ourselves grace. If we have any kind of cognitive impairment, we have to be patient with ourselves. We have to give ourselves grace. And what I mean by that is we have to give ourselves grace that even when we didn't have anything wrong, we had good days and bad days with our thinking. And so just because we have dementia, it's not unreasonable to expect that we're going to have good days and bad days with dementia. And so the first thing I want to say is ideas, there are phases when we can still actively work on thinking processes. So when somebody has a mild cognitive impairment, which is a pre-dementia phase, so somebody is at, I talk about it, subjective cognitive impairment. What does that mean? It means I know I'm having trouble thinking, but nobody else is going to notice I'm having trouble thinking. Okay. I know I'm having trouble. I realize I'm not thinking as well as I used to. Then the next level underneath that is called mild cognitive impairment. Well, mild cognitive impairment is the first time somebody is able to start to pick up truly that something is going on. And where this usually spills out is it starts to impact people who are younger, who are still working. It starts to impact them, and then it starts to mean that they're making errors at work, and people start to notice. This is the first time that when you actually take a cognitive test, that a cognitive test will likely show that you're starting to have trouble with your thinking. It doesn't mean you have dementia. It just means you have mild cognitive impairment. Now, having said that, mild cognitive impairment turns into dementia about 20% per year. So over 5 years, people with mild cognitive impairment are more likely to develop mild dementia in the next 5 years. But it doesn't mean that if you actually have mild cognitive dementia doesn't definitively mean that you actually have dementia. It just means that you are starting to show signs that you're having trouble. And then mild dementia is kind of divided up between the beginning, when you can still learn highly valued, what you want to learn, new information, and then later on where people do not learn new information anymore. When you cannot learn information anymore, that's where we split between rehabilitation, or being able to improve function, which is where cognitive activities to improve function would be helpful, and habilitation, which means we want to prevent something from getting worse. We want to maintain the status quo. We want to keep the person at the best ability to function. So in the mild dementia range, that's where that split occurs. At the beginning of the mild dementia, when people are still starting with mild dementia, they can still learn highly valued to themselves. Just because I value the information doesn't mean that that they're going to learn it. For example, I know you're safer with a walker. I want you to learn how to use a walker. I want you to really value it. But if you don't value it, you're not going to learn how to use the walker. because you don't care, right? And so at the beginning phases of the mild dementia, that's where we can still do cognitive activities to improve and prevent further decline. Once we hit the habilitation stage, we do want to work on activities that we can, but the focus needs to change. So let me give a few examples of things that you can do in the rehabilitation phase. When you have mild cognitive impairment, when you are wanting to work on preventing it from getting worse, there are a couple of websites. One is called Lumosity. Unfortunately, most of these are subscription-based, but lumosity.com, they have a subscription-based cognitive activities that you can actually work on different things that are typically in the executive function range to help prevent your thinking processes from getting worse. It works on working memory, which is, that little repository we all stick in a little bit of information in. It can hold about 8 pieces of information before our brain pitches it out, and it's before it goes into short-term memory. So when we have it in the repository, we can only keep about 8 pieces of information in there. So what these games do is they actually work on expanding how many pieces of information you can hold in your head. So a good example of working memory is, for example, trying to memorize somebody's phone number. 864-321-0648. 864-321-0648, right? And repeating that and putting it in your working memory long enough so that you can go get a piece of paper and write the phone number down. So that's an example of using working memory, right? So a lot of these activities, Lumosity has one, Brain HQ has one. There are a lot of these different things, and lots of guys, a phone is a phenomenal thing. It's an electronic brain. There are a lot of adult cognitive games on a phone. I'm not talking about things that are just, point and click type things, but actually things that you have to think and reason through. So that's where I would start when you have mild cognitive impairment. And if you have somebody who can help you with a computer, then you can even use it into the mild dementia range. You may need more and more help with some of the harder things. And what I mean by harder things that we have to think through and plan. How complicated is it to use a computer? It's pretty complicated. You got to open it. You got to make sure it's got a battery. You got to plug it in. You got to put it on. You've got to, log into the computer. You got to find your passwords, all of this stuff. So lots and lots of stuff. So you've got to go to the right website. So when we're using computer-based training, we want to be sensitive that when we're to a point that we need assistance with that somebody's walking along with us. But there are a lot of pen and paper type of activities too. If you're a words person, you want to use numbers. If you're a numbers person, you want to use words. You don't want to make anything that's routine and familiar, anything that is something that we intuitively do that we don't have to think about. That's not a cognitive activity. We actually have to think about it. So if your kids homeschool, or if you've homeschooled, there are lots of homeschool resources out there that have pen and paper books that can work on critical thinking skills and all of these kinds of things that are a little bit more, pen and paper based. So there's a lot of different activities you can do. Now, when you get to the habilitation part, which is where people aren't really working on being improved anymore, where we're not working on trying to improve function, but we're trying to prevent decline, it doesn't mean that we stop doing these kinds of activities. The activities just need to look a little bit different. And this is where a good occupational therapist comes in, because any activity can be a cognitive activity. Any activity can work on your thinking. Any activity can be made easier or harder. And so think about a cooking activity, right? An unfamiliar cooking task, something you've never done before, where you have to write out a shopping list, go grocery shopping, bring everything home, sort it out, take the recipe, follow the recipe, know all of this stuff. So it can be very complicated, right? All the way down to the only part of the activity that the person that you're wanting your loved one to help you with is maybe cracking an egg and then beating the egg. So any activity can be made as easy as anybody who can hold something can do something, to as complicated as we want to make it. So ideas and things to work on cognition, we've got to know where the person is. And when a person is more in a habilitation part of the game, what we want to try to do there is we want to facilitate enjoyment. It's not necessary. Yes, the end product is important, but if the end product is reliant on them, it may not ever necessarily be successful, and then they may not feel successful. So you supplement what they can do and you help them be successful. They may not be able to do it by themselves. They literally may need you to be right there and help them step by step along the way. And that the end result is that the person feels the success of the task because they participated in the task, because they're not necessarily going to remember that they didn't complete the entire task by themselves. So that is question number 2. Does anybody on live have a question for me tonight? I love me some questions. You know me, I can talk all night long. So the next question, this one's a great question, actually. This is, one of those topics we don't like to talk about. Nobody wants to talk about anybody's bowel movements, right? Nobody wants to talk about their own bowel movements. Nobody, but being constipated is miserable. I have only been constipated a handful of times in my life, and I don't want to ever have that happen again. It is miserable. So I think constipation and dementia is something we need to talk about a lot. So let's just briefly touch on a couple of reasons why. So this was from Nishida. And Nishida just got engaged. Congratulations. I will try to remember to tag you in this. So constipation and dementia. So she said, Mom is not actually having urinary tract infections, but we've noticed that she isn't pooping as regularly, right? She gets in a really bad mood when this happens. And yes, she will get in a bad mood when this happens. I get in a bad mood when this happens. Is there something medically changing inside? And so Nishida, like I said, congratulations on your engagement. It looks super neat. Constipation. So why does lots of reasons for constipation. Constipation is it is something that happens a lot more. One reason for constipation is medication. Oftentimes medication has a side effect of constipation. Ironically, either constipation or diarrhea. Go figure. Lots of times medication has a side effect of cognitive changes. But let's say the first thing I would recommend you look at is what medication, or is there a change in her medication? Is it a new medication that's causing her to be constipated? So medication, I would call the pharmacist. I would say, my mom's gotten more constipated lately. Is one of these medicines, can it be causing constipation, etc.? That's one part of it. The second part of constipation is your mom's not moving as much as she used to. So because she's not moving as much as she used to, it is definitely hard. I mean, our bowels move because we move. We're getting up, we're moving around, that helps our bowel movement. Yes, our bowels are doing their thing without us even thinking about it. But moving around helps your bowels move. Exercising helps your bowels move. Your mom is not drinking enough, probably. Lots and lots of water. Water helps you not be constipated. A lot of people with dementia don't want to drink a lot. And then a lot of people with dementia, when at the beginning they don't want to drink because then they're having to run to the bathroom and they're scared they're not going to make it in time. And then later on they just either forget to drink. I'm not sure if they forget to drink or if they're just not thirsty anymore, but people will stop drinking. Or they've never liked water. I love water. I drink hundreds of glasses of water a day. But a lot of people don't drink enough fluid. Coffee is a diuretic. It will dry you out. So coffee doesn't help, even though it's a stimulant. It can sometimes help your bowels. if you're sensitive in that way. But people aren't drinking enough water, and then they don't eat the same foods that they've always eaten. They eat a lot more foods that are palatable to them, and they're not maybe getting as many of the same types of roughage, the same types of fiber in their diet. So some ideas, some strategies, right? Exercise is good, making sure she drinks water, front load the water, try to very first thing when she wakes up in the morning, have her drink a glass of water, because we lose a glass of water a night when we sleep, actually more, about a liter of water when we sleep. So try to encourage her first thing in the morning, before you give her coffee, before you give her anything else to drink, give her some water, see if that helps her stimulate her bowels to move. Then, like I said, medication. So some off the shelf, not medically, and I'm not a physician, I cannot prescribe medication, but prune juice, warm prune juice can make a big difference. Stewed prunes, if you can get somebody to eat stewed prunes, they can make a difference. Anything that would have somebody, things that typically would make somebody's bowels move, would be good. You can try some Mucinex. Oh, good grief. Stuff that you put in the water that you dissolve, that's fiber. And my brain totally fritzed. I'm not going to come up with a name. It starts with an M if you live in the United States. You can use some other things like some stool softeners. When people's bowels haven't moved regularly and you just want to give them a low dose stool softener every day so they don't get bound up. So that's an option. Don't give her any medication without having checked with a pharmacist or a doctor. Make sure that she can take those medicines, right? Because I am not a doctor. I'm not a prescribing provider. So those would be some things that I would consider. I can tell you myself that for me, a little bit of coconut oil will always make my stomach go. Not too much, because then I go 45 times a day, but not, just a little bit of coconut oil. So sometimes people try that. Apple juice, some people have success with apple juice. There are lots of different strategies you can try to help somebody with constipation and dementia. So we want to try to stay away from things that are going to be like hard stimulants on her stomach. Things like suppositories and things like that may be a little challenging with someone with dementia, but they are certainly doable if we get to that point. So that is dementia and constipation. And I have a couple comments, right? Metamucil, thank you. Thank you very much. I told you it started with an M. I got Mucinex on the brain, and then I couldn't come up with a Metamucil. Metamucil is exactly what I wanted. Thank you, whoever you are. It adds fiber to your diet. Yeah, there are lots of different off-brand names and so on. And so there we go. So the next question, if I can find my questions here, this one kind of is on the other side of the spectrum, weight loss and dementia. And this is Lisa. Lisa, welcome back. We missed you. I missed seeing your comments. I missed seeing your questions. I'm so glad you found us. I'm so glad you found me again, and that we made Facebook friends again since you've been in Facebook prison or got kicked off or whatever happened. But welcome back. I'm so glad you're here. So Lisa's question, and I am going to read it here. She says, I've missed this group and glad to be back. I have apparently offended Facebook somehow and had been deleted. And she says her dad started not wanting to eat and in about 2 weeks. And we went to the doctor yesterday or a couple of days ago, whenever this was, and he's lost 10 pounds. And when should she be concerned? So weight loss and dementia is definitely something that we want to be aware of. And it's something that we want to pay attention to. Some people with dementia at the beginning, they eat a lot more and they gain weight. And then, that can be a problem in and of itself. But most of the time, people with dementia over time, long enough, and Lisa mentioned the doctor didn't seem too worried because dad is not small yet. Well, no, your dad might not be small, but we definitely don't want him losing weight. So why is he losing weight? what are some ideas or what are some factors that could be contributing to him losing weight? Is he forgetting, I know you have the nursery and those kinds of things. Is he forgetting to go eat on his own? And so therefore he's not eating as frequently as he did, and you're still thinking that he's going to go get himself something to eat. What are other ideas, what are other things that can happen is that when you put a big old plate of food in front of somebody with dementia and they look at it and they say, "Ooh, I can't do that." And then they don't even try because it's overwhelming. So sometimes if there's too much food on a plate, a person with dementia shuts down. There's actually a research study that shows that food being presented on a red plate has better success for people to actually be able to eat and stimulate their appetite. So sometimes putting food on a red plate may make a difference for a person who's lost their appetite with dementia. What happens too is people's taste changes, their taste buds change because of dementia. Food doesn't taste the way it always used to. And the last thing that people can still taste is sweet. So they tend to want to eat sweeter food because that's what they can taste. I've had a lot of my patients recently with COVID tell me they still can't taste their food, and so they have no appetite because they can't smell, and because they cannot taste, they struggle, and so they lose weight. So somebody with dementia, if they're not smelling as well, that can impact appetite, which can cause weight loss. And so some strategies, Lisa, some things that you can try. You can try giving your dad less on his plate, so it's not as overwhelming. More frequently, give him snacks throughout the day. Put food out that's visible so that if he just happens upon it, that there's food that he can pick up and eat, like an apple, a banana, whatever. Try to present him more frequently throughout the day with just little snacks instead of one big meal. Most people have a preferred meal of the day. Most people have one meal that they're like super hungry for. So try to get him to eat most of that meal. Some people do better if you just present one food item at a time. Is he forgetting how to use a spoon and a fork? Is that why he's not eating as well anymore? Sometimes people need to actually have finger foods in order for them to do the hand to mouth because they've forgotten how to actually use a spoon, a fork, a knife, those kinds of things. So if your dad's going through some of those changes, it may be because he's not feeding himself anymore because he really doesn't know what to do with the utensils. I'm not saying that is the particular case in his case, but just pay attention to that. Does he try to pick up food with his fingers anymore? Does he do better when you give him a sandwich? And if he does, if he doesn't have chewing or swallowing problems, if he seems to do better with finger food, try to give him food that he can pick up with his fingers. Who cares if he eats, something off of a bone, as long as he's eating, right? And when to be concerned, 10% weight loss in 6 months is a lot, you gotta pay attention. I wouldn't necessarily worry about it too much right now because you say your dad's a big guy, but you might want to just start a diary and trend his weight loss so that you can, independently of the doctor, maintain and see how he is doing over time. Okay? So Lisa, welcome back. I am so happy to have you here. And if anybody is on live, please put in comments live. If you're watching this on the replay, let me know in the replay. If you're watching this and you're not a part of my group, it's called Think Different Dementia Education Group, where I do a lot of educational offerings in there to try to educate people more about dementia. It is certainly, you're welcome to join. You're invited to join. I would love to have you there. And so I am super happy to be here tonight. We have a couple more questions tonight. Let me pull up the next one. And this one was from This one was from my friend Lori, and I know Lori's not watching live tonight, but she usually watches on the replay because, yay, Lori! Lori is getting the opportunity to go back and visit her husband. So we're going to talk about wheelchair positioning in a nursing home. And then her other question was, is it necessary to be upright when eating? And so here's Lori's questions. Are there recommended positions for somebody in a wheelchair? She says her husband is seated in a wheelchair by the facility's CNAs, and each person positions him a little bit different. Sometimes the back of the chair is reclined and the footrests are raised, so he's laying down. Sometimes he's sitting more upright. And she wanted to know, is there a right way to sit in a wheelchair? So yes and yes, but like you mentioned, Lori, we want to make sure that he is alternating his position. So a reclining back wheelchair does this. The back reclines. And so, yes, your first question, is it necessary to be upright when eating? Yes, he should be at a 90-degree angle when he's eating. They should not have him in a reclined position when he is eating, when they are feeding him, because you're more at risk for aspiration pneumonia if you're laying down and you eat. It can go down the wrong way. It can go into your lungs and you can get aspiration pneumonia and die. So they should have him at a 90-degree angle when he is being fed, whether it be breakfast, lunch, dinner, doesn't matter, whenever, 90-degree angle. So in a bed, you bring the head of the bed up as high as it'll go while you're feeding somebody in a bed. Then after they have been fed, you don't want to recline them back for about 30 minutes to get the food to go and go all the way down. So yes, positioning somebody in a wheelchair upright when you are feeding them is 100% correct. Now back to discussing wheelchair positioning in a nursing home. So my guess is there's a couple of things that go through my head. The first thing is, you mentioned in your comments to me that he's kind of hard to reposition. My guess would be that they're using a lift to transfer your husband. So if they're using a lift to transfer him, having the seat back reclined actually makes it a little bit easier to get him in the wheelchair. Having said that, once they have used the lift to get him in the wheelchair, they should have two people. They should never be using a lift with one person alone. You should always have two people. So what they should do when they're done with that, the sling shouldn't typically be remaining under the person. It can cause skin breakdown. They should be sitting him up and removing the sling from underneath his bottom. And then with two people, they should try to boost his bottom back. So oftentimes people, when they're reclined back like that, they actually slide out of the wheelchair. So you might want to ask the nursing home to have the physical therapist or occupational therapist, whoever in the nursing home does seating and positioning, actually pick him up to do seating and positioning with him to find the optimal seating system for him. That is a covered service from Medicare, and somebody in the facility should be pretty proficient in being able to help determine how to do this. When somebody's sliding out of the chair, it can cause them to fall. It can cause them to have skin breakdown because they're not sitting on the right bone. Yet they're not sitting properly. They can get shear on their bottom, on their sacrum. So yes, I definitely would recommend, Lori, that you have them pick him up for Medicare Part B seating and positioning therapy. And if not, then you be the squeaky wheel. And when you come in and he is not well positioned, you go get the nurse's aides and you tell them, please, will you help me reposition him? He doesn't look comfortable. And then the gap between his back and the chair with no support for his lower back, I would first want them to reposition him in the chair before we stick something underneath his back. Yes, he's uncomfortable. When he's in that position, he is uncomfortable. So that is what I would say your role needs to be, Lori. Your role needs to be squeaky wheel and to go get the PCTs or the CNAs, whatever they're called at that particular facility, and ask them, please, will you reposition my husband? He is not comfortable in this position. And then have them reposition him. Do not ever be afraid, if you have a loved one who lives in a nursing home, to ask for help for your husband. That is, or your loved one. That is what you are there for. You are his eyes and ears. You are his voice. So don't feel guilty. They are being paid to do their job. And if they don't do it spontaneously without your prompting, then they need to do it when you prompt them. So don't feel guilty about it, Lori. Do not feel guilty. You have to be his eyes and ears. You're his squeaky wheel. Okay? So I have one question left. I think it's going to be a shorter program tonight because it's kind of quiet out there. That's okay. If you're watching this replay, put replay in the comments. If you watch this live at any point in the time, you can put live in the comments. If you're not a part of my group, it's called Think Different Dementia Education Group. I welcome you to join. I would love to have you there. It is truly to do education. And so the next question is from my buddy Steven. Steven says, hey Liz, we are hopeful we can have mom placed in the memory care by October the 2nd. That's great, Stephen. That's wonderful. Any tips on how to bring the subject up to her? We were told to tell her one time and let her forget, but I just know Dad will bring it up repetitively because he wants her to be able to pack up for the move. And then he said, sigh. I think he still thinks he can reason with her. So great to have you here, Stephen. You and I have been walking this journey for about a year now, a little over a year now, and thank you so much for everything that you have done for me. How to talk to your mom about going to memory care. So the memory care says bring it up once, mention it to her once, and then let her forget. I'm perfectly fine with that. I would even be perfectly fine with you not actually saying anything to her about it, because in all of our conversations and descriptions of everything that you have mentioned, it may just cause your mom anxiety or a challenging behavior to precipitate itself. But then you know that Dad's going to repetitively bring it up because he wants her to be able to pack up for the move. We know that that's not possible. So you need to kind of preempt that away from Dad, Stephen, and start packing what you know mom can take, or get your sister to help pack your mom up, and preempt this from Dad, and that you feel like your dad is going to keep bringing it up because he wants mom to be able to help with the decisions about what to take. Mom's not at a point where she can make those decisions anymore. And I kind of actually think that Dad might not also be in a place to be able to make those decisions anymore. And I know you know not to reason with your mom, but trying to reason with your dad's probably not a good idea anymore. We want to try to do things maybe a little bit differently. So how to transition your mom to a memory care? You want to go for the emotions behind it, right? When somebody, it's a transition, any transition for your mom is going to be very difficult. It's difficult for anybody when they transition to any different place, even when we move, right? Anybody who moves from one place to another, they have issues when they move. When you go to a hotel, we have issues. So it's going to take your mom, when she transitions from home to a memory care facility, it is going to take her anywhere from a month to 6 weeks to get her head wrapped around it again. And in that first little bit when she moves to the memory care, you need to expect that she's going to decline. It is very likely that she's actually going to be more confused, and that is normal. And just because it happens doesn't mean that you didn't make the right decision. It is a part of what happens with anybody who has cognitive impairment. They use their normal routine to cue them about what's going on and what's coming next. So her normal environment helps to keep her on track. So now she's out of that normal environment in an entirely new environment. And it will take her brain about between 3 to 6 weeks, 4 weeks to 6 weeks, for that new unfamiliar surrounding to now become familiar. It's not that she's necessarily learning new information, it's just that the newness is going to become familiar and routine to her over time. So the very first thing to expect, Stephen, when you do move mom into the memory care unit is that mom is going to possibly decline for a period of time. The memory care facility may tell you not to come visit for a week, 2 weeks, 3 weeks. Every facility has their own way of looking at that. Some facilities let the families try at the beginning to come and be there and see how it goes. If it causes agitation when you leave or exit-seeking behavior, whatever happens, they may decide to ask you to not be there for a period of time. Some people, when they move a loved one into a memory care facility, want to give themselves just some time to get, themselves used to the change and purposefully stay away. They try to call. There are lots of different strategies. Each person is different. Each facility is different. So I'm not going to tell you what you should do or shouldn't do, but you should listen to the facility. The facility has done this more than you and I. That is what they do. They have hundreds of people move in a year in their business, etc. So they are the best people to help your mom transition from home. And so if they say stay away for 2 weeks, stay away for 2 weeks. It's not that you don't call the facility and say, hey, how's my mom doing? You can be involved. You can still ask questions. You can still be there, but maybe not be there. Give her time to get used to the move. And so back to what you were saying about dad wanting to, keep telling mom that she's moving. You might need to keep working with your dad to try to circumvent it so that he doesn't keep asking her. I'm not quite sure how one does that because I struggled with that with my dad. I'm like, Dad, don't say that to mom. But anyway, so hopefully that was helpful. If anybody on live has a question, this was the last of my pre-prepared questions. I would love to hear if anybody else has a question. So we did 6 questions tonight. How does one die from dementia? If you're watching, if you hopped down late, how does one die from Alzheimer's or dementia? Some cognitive ideas or ideas how to work on cognition. Constipation and dementia was the 3rd question. Weight loss and dementia. And when to be concerned and some strategies to help for weight loss. We talked about some wheelchair positioning in a nursing home and to try to be able to help somebody sit upright when they're eating, and then transitioning to a memory care unit. So that was tonight's program. Do any of you guys on live have a question for me? I am happy to answer any questions. If you want to, you can always message me on Facebook. I'm always here to answer your questions. I love answering questions. If you're not a part of my group, it's called Think Different Dementia Education Group, which the sole purpose is to try to educate people about dementia. And so I would invite you to join and invite you to come learn some more. It's a work in progress. Every week's a little different. I thank you guys for being here. Like I end all of my programs every week. I try to end them with the Lord bless you and keep you. And I pray for all of you not daily by name, but I do pray for everybody daily, kind of, people who are living with people with dementia, because it truly is a journey. But just because a person has dementia doesn't mean that they cannot still thrive. It doesn't mean that they cannot still have a good quality of life. And the reason my company is called Think Different Dementia is because I want people to think different about dementia. I want you to think different about how to approach it, how to be with people with dementia, how to take care of people with dementia. So the Lord bless you and keep you. And I will be back again on Saturday morning at 8 a.m. Eastern Standard Time, well, Eastern Daylight Time, whatever it is. So please join me there again. I will have some extra questions prepared for you for then. And I am going to see you guys again next week. Thank you for being here.